Now we're going to proceed quickly to Captain Susan England. She's a career Indian Health Service commissioned officer. She's triple boarded as a certified nurse midwife, a family nurse practitioner, and child and family psychiatric nurse practitioner. She's had many titles, many responsibilities, and she started all this with a postmaster's in nursing and family nurse practitioner at the University of New Mexico in 1997. She also has a bachelor's of science in nursing from Evansville, and she lives in South Dakota in a small organic ranch with her husband, and she has cattle, registered meat goats, and pasture poultry. Doctor.
Good afternoon. I'm excited to be here. This is my first breastfeeding summit, so I've been learning much from many of you from the presentations and during the lunchtime. And yes, I did know what I wanted to be when I grew up. It was just my career path led me in many ways. I knew growing up in rural Indiana that excited me. Listening to all the Hoosiers, I always say I'm a Hoosier by birth, South Dakotan by choice. And unfortunately, when the director of the State Health Department in Indiana showed all the counties for Indiana, which I already knew, my county of birth, which is Rush, has not had in-county obstetric services since the 80s. I was born in that county. You have to travel to the surrounding counties that all have delivery services between 25 to 30 miles one way, which is not fortunate for my sister-in-law on her fourth pregnancy. It was very close getting to the hospital, so I see the need. With my career direction, I always wanted to be a nurse. By the time I was in junior high, I knew that I wanted to be a nurse midwife, and when I got to my schooling in New Mexico, I was practicing in the Indian Health Service as a staff nurse. I felt it was important also to be a family nurse practitioner because I knew I always wanted to work in rural areas of need. Then in 2008, I was working in Indian Health Service in the Great Plains area where I'm the current maternal child health consultant there, and there was a strong need for behavioral health services, especially in the women I was taking care of. It would always start, I've never told anyone this before, and many times I knew where the path of this story was going to lead, and I knew I needed to help women more. So I went back to school to become a child psychiatric nurse practitioner. And even though I have a consultant role now, I still practice clinically on the Pine Ridge. In the next couple of weeks, I will be pulling my labor and delivery call. Also with staff shortages, I also cover in the clinics too, which works nice being credentialed. I can just slide in. So I still try to walk my talk for that. So let us begin with the Indian Health Service. We've had a change toward more family-focused care that became with the Baby Friendly initiative that was started with Let's Move in Indian Country. That was part of an initiative by Michelle Obama to decrease rates of childhood obesity in Native American and Alaska American children. For that, with the 13 baby-friendly hospitals, they were designated in 2014. I'm excited to say the first hospitals that were designated were in the fine state of South Dakota. And currently in the Great Plains area, we are up for redesignation. The first redesignation survey will occur in July in Quentin Burdick facility in Belcourt, North Dakota. The next one will be happening in August at the Pine Ridge facility for that. And then the coming year in 2018, there'll be another 4 until the rest of the redesignations. Also with the tribal facilities in 2015, Cherokee Nation and Chickasaw Nation in Oklahoma were designated. And I'm going to mispronounce this because it's in Navajo. Teshhutsui Medical Center, which is in Fort Defiance, Arizona, was designated in 2017. So exciting times are happening for us. And with the baby-friendly sustainability, with the policies, each individual hospital creates their own breastfeeding policy that's unique to each facility. also is incorporated cultural traditions too. We renew the breastfeeding policies annually as a chart review, and we update as evidence-based changes occur. And that goes with the baby-friendly leads that are in each facility. And with accountability, all new employees, including contracted staff, frequently we do have contracted staff that cover in our maternal child health areas. They receive that at their orientation before they start work to begin seeing and caring for patients. We also have it in our performance reviews, which we call PMAPs. There's an element for baby-friendly that if people are following through on their baby-friendly and ongoing continuing education. And then with reporting the baby-friendly activities at the local and area and national levels, locally, each hospital has nurses, providers, the leadership staff that meet to know what's happening with baby-friendly with our statistics. Area and nationally, we have our own data mart. The facilities submit their information yearly to the baby-friendly data mart. We also have an Indian Health Service data mart, and at the area level, designated people, I'm designated for the Great Plains area, that we review the baby-friendly activities that are occurring at each of our delivering facilities. In the Great Plains area, there is 3 hospitals. There's Quinton Burdick up in Belcourt, North Dakota. There's Rosebud and Pine Ridge in South Dakota. And we have many more facilities. We also have many other hospitals, but they are not delivering facilities. Resources are sent, they're referred out to deliver at other facilities, but they come home for their pediatric care, and frequently they get their prenatal care. They just don't deliver at health centers or some of our smaller rural hospitals that don't have surgical capability. We do not do obstetrics. For that, with our breastfeeding statistics, what we're looking at, we haven't got the 2016, 2017 that's been published yet, but it's very similar to where we're hovering at right now. It's around 35% of continuation of breastfeeding at 2 months. For upon initiation, depending on the facility, the area that you're at, there's an 80 to 90% initiation rate for breastfeeding. Some of our challenges that we have, many of our areas are rural and frontier. The majority of the sites in the Great Plains area, which I'm very familiar with, where I've spent most of my career, most of them are cited as frontier. There's less than 2.2 people per square mile in the facilities. Many of the counties do not have obstetrics providers for that, so you have to travel with the weather, with the distances, muddy roads up in the Great Plains area. It's frequent snowstorms. Is sometimes if contractor providers are coming in, they'll be driving 2 to 4 hours to get to facilities. Patients can't make it in, providers can't make it in. Also with the poverty level, when people are traveling an hour or more, deciding whether to feed your family or drive for a prenatal clinic visit, if you feel that you're doing fine, that's the decisions that are made. Also too, there's frequently limited job opportunities. Many times people are driving an hour or more each way to go to their jobs, and they have limited time off. That can be hard to coordinate the schedule. Some of the things we've done in the Indian Health Service is we've extended clinic hours. Many facilities go from 8 o'clock in the morning till 6:30 at night. We've also opened up weekend clinics in the majority of the facilities. Limited access to resources. Many people were talking about the food desert. I can relate to that for myself personally. It's 50 miles round trip to the one grocery store in the small community that I live in, and it's what's in that small grocery store. If I want to go for a larger variety, it's 120 miles round trip that I drive to Rapid City myself. I do a lot of gardening. There's been a lot of gardening initiatives in the Great Plains area in North Dakota, South Dakota through the extension agencies, which is a nice option for people. They're starting to form farmers markets, which is very good, and involving the youth to change how things are happening. With historical trauma, again, due to the distance, in the past, this is changing. We're having school systems that are closer to home. Many people, especially in the grandparents and beyond the generations, they were sent to boarding schools where they may only come home infrequently, maybe once a year, so they don't have that cohesive family history of seeing other family members breastfeeding or being taught the different things that are important prenatally due to being gone for so many years for that. Also with the historical trauma, it was until in at least the Great Plains area and many other areas of Indian Health Service, until the 1940s, you had to have permission from whoever was the leader to leave the reservation if you were running livestock, to even sell your livestock to make income. And that's had a big impact on people. Sometimes people come in or they're very fearful. I've been told before, as a provider, I know I haven't been in, I've been working, and the hours don't work with the clinic schedule. Are you going to turn me into CPS? And I say, no, I am not. And I tell people to let me know so I can write notes or see if they can get off. Or if you tell me you're running late because you get off work at 5:30 and we close the clinic at 6 o'clock, just let me know you're coming and I will stay and I will see you. So that's some of the things that we've been working to overcome in the Indian Health Service, some of our challenges. For that, with our breastfeeding support challenges is lack of adequate staffing and training responsibilities. And as the medical student will know, I was actively recruiting her. Come, when she finished residency, please come work for me in the Indian Health Service. And again, it's many times because we work in frontier areas. People worry if they come, if their families are going to have quality educations, if their spouse or partner will be able to find a job. Also for training opportunities, when we're very short-staffed, it is very hard because we need to maintain the care that we're providing to the people that we serve, is to send people for training if we're very short-staffed. Some ways we've overcome that is through Adobe Connect conferences, working sequentially of sending groups of people throughout the years. Also with prioritizing healthcare needs is sometimes, unfortunately, maternal child health isn't the top priority, which I feel it is because that is in my realm, but prioritizing limited resources for the needs of the people that we serve. This is an exciting concept. We've gotten seed startup money from headquarters, Indian Health Service, the nursing division. For group prenatal care, we've had centering training in multiple facilities throughout the United States. And this is very important in the areas where women deliver off-site, is that we're incorporating the group prenatal care concept so they have a cohesive group, even though they may deliver at another facility. Oftentimes it can be 100 miles away, is that they have a support system in place in their home community. Public health nursing is doing a lot of this great work. This picture here is in Standing Rock in North Dakota. Is actually the public health nurse contacted me and said, we don't have a delivering hospital, but we want to do this. We want to make this happen. They contacted tribal leadership, and the tribe, the Standing Rock tribe, partnered with them, and they offered them a brand new building in a modular building where they have 2 rooms with its own separate entrance down the street, and it's really taken off. And the tribe is fully backing it and supporting it. So that's some of the exciting activities that are going on. Other strong programs are in the facilities in Oklahoma and also in Arizona to have formalized centering group prenatal care. Also in South Dakota, with the urban center, they were doing group prenatal care, and they decided that the whole family could come. It could be grandma, grandpa, aunts, uncles, father the baby, and they've had good success with that too. So each individual community is defining and determining how they want to provide prenatal education and support. So it's the community telling them what they feel is the most important and what they need, and I think that's awesome. For that, for professional staff lactation education with local hospital training, again, like I said earlier, is when someone comes, whether they're coming full-time or they're coming to contract with us, we have a health education program called HealthStream where they do modules online, and depending on what your job role is, if you're a direct care provider, say OB/GYN provider, nurse midwife, also, if you're one of the nursing staff that has direct contact with OB patients, you have more formalized mentoring training, one-on-one training, sometimes rotating to the OB floor for more hands-on work with lactation education. But even if you're there for a limited period of time, everyone is initiated into the baby-friendly standards, ongoing training, all the way down to the housekeeping staff. There's general all-staff meetings where we bring out the latest evidence on breastfeeding, promoting breastfeeding. With continuing education programs, again, headquarters has been very generous with the multiple areas. is we've had the majority of our public health nurses have been able to receive training as lactation educators through the University of Arizona. And then many of them, and I've provided in my area seed money for people to go on to receive training and take their exam for certified lactation consultants. We also have some that are IBCLC certified too, and more people are wanting to be part of this because they understand the importance of breastfeeding, or they breastfeed themselves, and they understand the challenges sometimes in the rural areas of finding the help that they need. But I find it exciting that many people are jumping on board and understanding the importance of breastfeeding and how that can help improve the families we serve, their lives for generations. With our public health nurse program, again, we were talking about the many areas that we do not have delivery hospitals, as the public health nurses are taking upon themselves where they designate one nurse specifically to be the lead for the maternal child health program. And we're trying to do some standardization across the areas. And currently in Indian Health Service, we're standardizing all of our prenatal care forms in electronic health record. I've been working on that quite a bit. We also have our own baby-friendly specific form too for nursing and the providers to evaluate breastfeeding or any ongoing cares and concerns. Some people may recognize this lady, many may not. Her name is Eleanor Gregg. She initiated the nursing service in Indian Health Service, and she actually started in the Great Plains area on the Rosebud and Pine Ridge reservations for that. She came in the 20s, and it's interesting reading her work as she was going and doing home visits, seeing the moms, seeing the children, and then she went on because she saw the importance of the need for public health nurses and the support for families in their home, that she ended up creating the Indian Health Service nursing component. She has an interesting book. It's a rare book, and if you guys find it, I encourage you to read it, because some of the problems then in the 20s, unfortunately, we still have now, but it's called The Indians and the Nurse. It was a book that was published in 1965, a few years before she died, but she talks about her time on the Rosebud and Pine Ridge reservations for that. With our maternal child health programs, and many people are here of cohorts of ACOG and the American Academy of Pediatrics. With ACOG, they've been commissioned by Headquarters IHS, Division of Nursing, to come do quarterly reviews. They come every 5 years to evaluate the maternal child health programs in the Indian Health Service facilities. They also go to areas where they do not have delivering hospitals, but there is still a high volume of maternal child health care. They came this spring to the Great Plains area and visited our 3 delivering hospitals. They're also going to be making contact, and more the group of ACOG representatives, OBGYNs, we're going to be coming singly, like 1 and 2, with their recommendations and to see how they can assist our facilities. They're starting a new program where they're going to come 2 years in a row. I'm very excited about that. I always say I welcome all the help I can get to improve the care of the people we serve. And the American Academy of Pediatrics, they also do reviews in the Indian Health Service, and they're coming this fall to the Great Plains area, and they're going to visit 5 of our facilities, and they also have regular contact with us, and they have very good recommendations, and in the past they've also helped with recruitment too. So I'm very happy to be working with ACOG and the American Academy of Pediatrics for that. Also, in many of our areas, if not all of them, in the Indian Health Service, each individual tribe has their tribal health board. This one's for the Great Plains area, Tribal Chairman's Health Board. They have their own division for maternal child health, and it's very nice working with them on projects, because with the collaboration, each of our resources we can do together, we can work collaborative on projects. And that's where I think we see the future going with more of the family-focused care, is we all work together. The Indian Health Service, the tribal health boards. Also, we heard the presentation by WIC. WIC has been a great help to us. They provide hospital-grade breast pumps to our moms that are breastfeeding up in the Great Plains area, and that's been an awesome resource. What the lessons learned along the journey is involve the community and the tribes in the program development, involve the entire families, the fathers to be, the grandmas, the grandpas, and provide training for the staff, ongoing training for the staff, make it a priority, especially breastfeeding education and training, and then developing programs and with adequate staffing is what we need, especially with lactation consultants, lactation educators, more specialized maternal child health nurses, advanced practice providers, OBGYNs, certified nurse midwives, pediatric nurse practitioners, and I can't forget my colleagues, the PAs, too. And does anyone have any questions about our program?
Well, I think you answered all the questions already. That was a beautiful presentation, and your quarters are awesome. I can't envision miles and miles of open plants.
Yes.
So thank you for
Yes.
what you
Okay.
do. You have a question?
Well, a comment, question.
Yes.
Thank you, Suzanne. I just wanted to mention to you that WIC is updating its breastfeeding trainings for staff. And I know some of your counterparts know about it, and I know you work closely with WIC, so hopefully they'll tell you. But for the one that we're developing now, it is for all staff. To be breastfeeding friendly and have some basic competencies, but we are working with a native IBCLC to specifically make a component, a cultural component for use with the native communities that hopefully will be useful for not only our the tribes that have WIC, but the other tribes that work with you at the Indian Health Service, because there's hundreds and hundreds of tribes nationwide that, and we only have 34 tribal organizations that have actual WIC programs. Right. So there's a lot that don't.
Thank you.
Hi, good afternoon. Ivanka from Samarkand. I love your presentation, by the way. It
Thank
brings
you.
back history, or for me and my family watching Walker, Texas Ranger, you saw the people dressed that way and you thought it was always a movie or something for me. But seeing that it actually do really exist, I'm happy to see that. And maybe my question might be a bit strange, but do they bring, because I know they mix their medications and their way of life into the medical system. So do they bring it over to the system, or how do you regulate it within the normal standards of living?
With the traditional tribal practices,
Yeah, and their medications and healing products and...
I can only speak in general to two areas. Prior to going to the Great Plains area where I spent most of my career, I worked on Navajo when I was a staff nurse, and the rest of my time's been in the Great Plains area. And when I worked in Navajo, and that would have been in the late 90s, before I went up to the Great Plains area, is women would still bring in their traditional child carriers, the cradle boards, and go home with them. And also with the belief system is when you go through postpartum, they would smear the first baby meconium on their cheeks. And when I first arrived, I didn't understand that, so I just asked. I knew there was a meaning behind it, and they said, that's so we will always be humble for our babies. For that, if you put your own baby's poo on your face, then you're going to be humble. In the Great Plains area, and again, the longer you're there, I've been going on almost 20 years up in the Great Plains area, so people know me because we shop at the same grocery store, because again, it takes you 50 miles round trip to get to the grocery store. So I see people in the grocery store, I see them at church, I see them in any local function or activity, and they'll walk up to me, is building a sense of trust for that. And sometimes if women have a lot of anxiety about their pregnancy, worry that something's going to happen to their pregnancy, I have referred them to their local holy person, and they do have blessing ceremonies for them. Frequently, a lot of times in the Great Plains area, is families want to take a piece of the umbilical cord home. They have, I can't think of the exact word, I want to say almost a totem, where it's a beaded bag. If it's a female, it's a turtle, And if it's a male, it's a lizard. And if you put it in there, then that's thought to keep the spirits away from the real baby. They go more toward the umbilical cord. For that, also with the wiping of the mouth, I have one mother up in the Great Plains area that accuses me of this is why her daughter talks so fast, because I was the midwife that delivered her. But whoever wipes out the baby's mouth, you impede part of your spirit on that child. So once I learned that, a lot of times if a grandmother, auntie, or a respected person comes, I ask them if they want to wipe out. It's not standard anymore to do the bulb syringe suctioning on a baby once they come out, but I say, do you want to do that? Because I always have like little gauze or other things on my delivery table, is I ask them that. And also it's still very much so is that the elders, you go to the elders for questions about healthcare. So when I want to talk about breastfeeding, I want to know, I ask the question like, were you breastfed? Did your mom, did your sister, did your aunties breastfeed? What does your family feel about breastfeeding? Because I want to get an idea, because you need to stand united with the family, not against the family for that. Also, a couple of other things is sometimes when they ask, what's the first thing you ask when the baby's born? What's the baby's name? What's the baby's name? Traditionally, many people wait until an elder comes or they have a ceremony to determine what the name of the child is going to be. And then in the summer, they may get their traditional name later at the summer at a wachipi, or what some people call a powwow. And then people will come and be honored, and they do a big giveaway for the child too. And then if unfortunately there's a stillbirth or miscarriage or an accident and a young child is away, is many people will do a wiping of the tears ceremony after a year, and many people have their hair long, they will cut their hair short in respect for their deceased one, is some of the things that I commonly see. And people will take their placentas home. If you bury it near the house, then your daughter will stay close to home. If you bury it near the corral, then your son or daughter will always, work with raising the livestock. That's some of the things we commonly see. So we always routinely ask if people want to take their placentas home, too, for that.
Thank you.
One quick question.
A quick. Actually, have two questions on the the drop off in breastfeeding that you see from delivery to that first month, the second month. What are the reasons?
I think you answered one of them when I heard you speak yesterday, is like you said, a woman will deliver on Thursday and she'll be back at work on Monday. Mm-hmm. I have many women like that, because if she does not show up at work, yes, she will be fired, and there's 20 people to take her place, and she may be supporting 20 or more people in her family. And in those cases, women feel guilty a lot of times, like, I don't want to let you down, Suzanne. And I'm like, you're not letting me down. Do what's best for your family. And I tell them, if it's hard, it's stressful, no matter how much breastfeeding you do, that's still better for your baby. Do what you can.
So, in the plain area where you are, which nations do the best in terms of breastfeeding duration?
I would say it's across the board about the same. The main tribes that we have is what people commonly know as Sioux, and there's different branches is Dakota, Lakota, Nakota, and then further north in North Dakota we have Chippewa. But it's all about the same.
All about the same. So the nation, the Lakota that are at Standing Rock right now, how are things going for them in the face of the pipeline issues?
With that, in the realm of maternal child health, they haven't done delivery since the early 70s. There's 2 facilities they can deliver at, because on Standing Rock, part of the reservation is in North Dakota, part of it's in South Dakota. If they live more close to the North Dakota side, they go to Bismarck, which is 70 miles of open prairie from Fort Yates, North Dakota, to Bismarck. If they live further south on the South Dakota side, then a lot of times they will go to Murrow Bridge, which is like 20 to 40 miles is what it is. For that, they do receive prenatal care. Dr. Tencher, she is a young lady from the area. She is providing the prenatal care up to 32 weeks. Then she works collaborative with the doctors that come down from Bismarck, and they come down like twice a week. Or they have contact with the doctor, the OBGYN in Mobridge, who does deliveries there, is what they do. But this is very exciting with the public health nurses for that.
Well, thank you very much, Captain Susan.
Thank
We
you.
could,